think we're to the point that we can get started. Good morning, everyone. This is Terry Kearns, the chair for the SURG Response Subcommittee meeting, which is what you are on here for this morning. So we'll go ahead and get started with the agenda. Crystal, can you do the roll call?
Yes, I can. Christine Payson. She's connecting to audio, so I'm going to come back to her. Dr. Stephanie Woodard.
Present.
Dr. Terry Kearns.
Present.
Shayla Holmes.
Present.
And we have one vacant space on our subcommittee. Gina Flores O'Toole has resigned from the subcommittee. So, and it looks like Christine is still connecting. But I do see her here. I think, Rosalie, do we need her to obviously have audio so she can be present?
To counter present, I would wait for the audio to work, but you have a quorum without her as well, it looks like.
Okay. Should we call roll again when I see that she has audio connected?
You could, or just note for the record that she's able to join at that time.
Okay. Maddie, do you mind keeping an eye on that? And then in the notes, you can mark the time in which she is. Oh,
yep.
I'm going to call her name again. Christine Payson, we're doing roll.
Present.
Great. So with that, we have more than a quorum.
Great, thank you for that. We'll go to agenda item number 2, which is public comment. And Crystal, if you would mind just reading the information.
Yeah. Public comment will be received via Zoom by raising your hand or unmuting yourself when asked for public comment. Public comment shall be limited to 3 minutes per person. This is a period devoted to comments by the general public, if any, and discussion of those comments. No action may be taken upon a matter raised during a period devoted to comments by the general public until the matter itself has been specifically included on an agenda as an item upon which action may be taken pursuant to NRS 241.020. If you're dialing in from a telephone, dial 669-444-9171. When prompted, enter the meeting ID 868-333-11069 and press *9 so the host can prompt you to unmute.
I don't see anyone for public comment. We'll wait just a moment to see if anyone calls in. Do you see anyone, Crystal, for public comment?
I don't.
Okay, we'll move on to the next agenda item, which is agenda item number 3. It's to review and approve the August 21st, 2023 response subcommittee meeting minutes. Those were sent out to all the committee members. So if there's any discussion, please bring that up at this point. If there's no discussion, I would look for a motion to approve the meeting minutes.
Christine Payson, move to approve.
Thank you.
This is Shayla, I'll second.
Thank you. So Christine Payson made the motion and Shayla Holmes seconded that motion. So the August 21st, 2023 response subcommittee meeting minutes are approved. And we'll move on to the next agenda item, which is our 2023 response subcommittee recommendations and discussion on those recommendations. So going back and looking from our previous subcommittee meeting, we had discussion on the first two, and our guiding principle on the 2022 SURG recommendations was to harmonize the guiding principle of harmonized public safety and public and behavioral health responses to substance use in our communities and state. Number one was to revise the penalties based on the quantity of fentanyl analogs and other synthetic drugs of high potency that are trafficked. That was moved forward as a BDR and became NRS. You can see on the slide. And then leverage existing programs and funding to develop outreach response providers and or personnel that can respond to any suspected overdoses and offer follow-up support referrals and services to the individual and loved ones following an overdose, providers and or personnel to be deployed to anyone being released from institutional and community settings, such as hospitals, carceral facilities, and other institutional settings who is being discharged post-overdose or suspected overdose. And I believe this one was moved forward from our last meeting. And then the ones we still need to talk about are number 3, support legislation to establish a statewide and regional overdose fatality review committees and recommend an allocation of funding to support the ORF to effectively identify system gaps and innovative community-specific overdose prevention and intervention strategies in accordance with established best practices such as the Bureau of Justice Assistance's Overdose Fatality Review, a practitioner's guide to implementation. And I know on this recommendation, we have Trey DeLapp on the phone, and I asked if he would give us an update on the status, because I know this was pushed forward as legislation in this past legislative session. So Trey, I would tender the mic to you and ask that you provide an update for us.
Sure. Thank you, Dr. Kearns, for inviting me to this committee. You all can hear me, right? We're only...
Yes.
Good. Thank you. So AB 132 was introduced by Leslie Cohen, and the original intent was to model using the state's OFR process for suicide fatality and other fatalities, was to sort of model that process and apply it specifically to opioid fatality reviews. The difference in this approach was it heavily emphasized a regional local approach. So it really wanted to take it down to the community level that comported with the best practices as outlined in the Bureau of Justice Assistance Best Practices Practitioner Guide. That was a great source of information. So the barrier we ran into was a fundamental lack of understanding of what a opioid or a fatality review is. So on the assembly side, we had support from the chair, and the committee kind of fell into place, but some of the legislators just were going along with the flow. They didn't really know exactly what this was, what it was for, et cetera, et cetera. It did pass the assembly, and then in the Senate, it encountered some strong opposition from the counties and from the Senate committee. The county's concern was, since they didn't know exactly how this would operate, that they didn't have the staff for it. They have staffing issues like everybody does, and they had some concerns about how much staff time it would work. One of the issues that was really important that I think is worth noting was, apparently in Nevada, if someone dies somewhere in the state, it's either Clark County coroner or Washoe County coroner that does the autopsy. So if someone dies in rural Nevada, apparently those autopsies go to, or those forensic cases go to those counties. So both of those, the Washoe and Clark County was concerned about the load on their already stretched coroner staff. Another one was a fundamental philosophical objection to fatality reviews as being effective. And I'm not sure if that was a policy practitioner public health thing, or if that was more of a kind of, sometimes in politics, people will be super critical or kind of hijack an issue because of a bigger concern. And in that scenario, I believe that could have been the reason, because the bigger concern was comprehensive public health for the state, period. and then some really interesting questions came out. And I think that's relevant to this committee as far as what you would like to see in expanding this. Here's some classic questions. Gee, will this change a death certificate? No. Are you going to use the PMP? Maybe. It depends on how this group works together. So, and then there was a lot of concern about confidentiality and liability and things like that. So certainly a best practice here. And I think the points I tried to make really clear was the only purpose of this OFR is to find out what, if anything, we can do to prevent future ones. And I think that's something I took from the Bureau of Justice Assistance's work is in other states where this is working. That was a philosophical core that the reason we're doing this is because we want to prevent overdoses and move quickly, deploy resources. And in some other communities, there were some really novel and interesting observations. So, you know, policy and politics, there's two things that go on here. So while this was a good policy, the politics got in the way. The ultimate comprehensive revision came out of a conversation, with Clark County Commissioner Marilyn Kirkpatrick, who was also chair of the Southern Nevada Health District board. And she had a very frank and candorous conversation with her about doing a Clark County opioid task force, and it delineated who would be on it, what sectors would be represented, and what they would do. And this, I think, aligns with some other stuff that she was aware of in a regional perspective. So basically, it's limited to Clark County. They will have this task force. The task force will be comprised of these people, and they will meet quarterly, produce a report, recommend policy changes, etc. So I envision that the product that comes out of Clark County may be scalable or adaptable to smaller communities in the state. And that's just a hope and a prayer. Who knows what it'll actually come out as. The other opportunity, I think, is, it's now up and running. They're soliciting applications and they're going to formalize the membership. I think the bill goes into effect October 1st. They can start meeting whenever, but I imagine in January they'll start meeting and doing whatever. One thing I'm excited about is that it includes a school district, and that this opioid fatality review concept builds on legislation from a prior session, which was harm reduction in schools with naloxone available in all schools who want it. So that's really a thumbnail sketch of this effort. I'd be happy to take any questions or dodge them.
I had a question, but I'll open it up to the committee members first if they have any questions. I don't see any hand raised. So Trey, my question is, so Clark County has agreed, if you will, to pilot this concept of an overdose fatality review as part of their opioid task force. Then do they push a report back to the legislation, or how does it go to see if it can be scalable to other regions?
So good question. Part one of that is they don't consider this an opioid fatality review in name. They consider it a task force that's going to look at data that, and I think this is it's just a nuance. It could also include overdose reversals that were successful. So it's not just fatalities, it could be overdose reversals. The tasks are that they will issue a report by December 30th of 2024 to the governor, the LCB, and publish, I imagine it. Included in that would be sort of what they came up with when they looked at stuff, and then if they have any policy recommendations. So as far as what could be scalable, I think that report or what they determine from their resources would show what is possible. However, we just have to put a big old caveat here that Clark County is a massive population center compared to Lander and Eureka and all these other things. So and that key detail I brought up at the top of the discussion here is that like coroner stuff is done not in those counties. So I think that's where it would be important to have rural communities involved in any sort of scaling piece. I think the most valuable piece would kind of demonstrate one practically, but also kind of theoretically, like if there were certain health officials or certain different resources in local or more rural communities, how could they kind of fill that function based on their resources?
And it's kind of a comment / question is, I've seen mostly throughout the US and other states that these overdose fatality reviews are done at the county level and have been most successful at the county level, as opposed to the state level. Was there any discussion or recommendation from that?
In preparing the research for this proposal, there was an interesting variety of ways that this was designed in different states. So in one state, a university operated the OFR, and they were designated by the state as the OFR operator. In Indiana, for example, there are lots of tiny counties, and then they kind of had interlocal agreements with little tiny counties working together and sharing information. In Kentucky, and this is just trying to recall this, they had something similar, but it was exclusively for prescription medication. So states kind of do it a little differently. I think that could be a holdover from phase 1 of the opioid epidemic, where it was really all about prescription stuff. But to your point, and this was heavily emphasized, it is more important that the community run this process, because anything that is going to be effective as an intervention is going to happen at the community level. Also, local community people can move much faster. And because of the diversity of this state, I think it's even more important that it happens at the community level. So that's my response to that.
Thank you. I appreciate this. I'll ask Dr. Woodard, if you don't mind. I know in the state needs assessment, and then the state plan, was OFRs part of that? I'm trying to remember the language from that.
It was, I don't remember the exact language, but it has been identified as a best practice for all the reasons that both you and Trey have noted. This really helps to pull together very specific information around what is occurring at a local level, and then allows community decision makers to have that information to then structure if there are needs for additional resources or supports within the community. Certainly, we can look to some of the overdose the fatality reviews for deaths by suicide as an example of how the richness of that information then also helps us to identify where there may be missed opportunities and gaps within the system that could be addressed to more readily available individuals who are at risk. So it was included in the state plan, but the exact language I don't recall.
Thank you. I appreciate that. I thought I remembered it from the plan. From my perspective, it sounds like this was one maybe we should follow, because it sounds like Clark County is going to do some work, and then we'll push out their report to the LCB and governor and the others and see how that works. And then possibly if it is scalable, or if it's, implemented as we can through the other counties. Maybe, Washoe would be the next to start, but any thoughts from the other committee members on this recommendation?
So, Chair Kearns.
Please go ahead.
Stephanie Woodard for the record. So what I would say is, what I recall is some of the guidance that has been pulled together around how communities can conduct their overdose fatality reviews are relatively flexible, and nothing is written in stone. And I think if anything, it provides ideas for how communities can align their practices with best practices, while also recognizing the limitations in resources and personnel that it may take to be able to conduct an overdose fatality review committee. So I would just say that I think moving forward, the more that we can promote that flexibility so that the recommendation can be adaptable to communities, their resources and their needs, I would like to see us be able to support that kind of recommendation.
Thank you. Shayla, did you have a comment? I thought you had raised your hand.
I did briefly. I just wanted to say that I support this recommendation, would want it to remain flexible as well, but I do want to make sure that we keep it flexible enough to be at that county or community level. We do have children's death reviews that happen at the community level or at the county level, and I think that they are fairly effective, and I think that those prove that this can happen at that level despite smaller communities or smaller towns. So I would continue to support this recommendation and would want it to stay as close to local as possible.
Okay, so it sounds like we want to continue to move this one forward, but perhaps some maybe changes to it in terms of, support legislation to establish the Overdose Fatality Review Committee, allowing flexibility as to the makeup and practice, and for it to be at the community level. Does that, and then of course, based on established best practices such as BJA's Overdose Fatality Review, a Practitioner's Guide to Implementation. And I think one of the other really important things that's in this already is looking at the prevention and intervention strategies, because we want to take this out, to Trey DeLapp's comment. It's not to change a death certificate, but it's to look, are there places throughout that interventions could have been done, or prevention activities to prevent these types of deaths. Is there any other discussion from the committee?
If I could make just a comment, this bill and the way it's structured, there's 15 members of the committee from social services, juvenile services, health district, primary, mental health, behavioral health, addiction medicine. So I think that's something to definitely take into account when taking this on the road through Nevada, is that they may not have 15 different people that could do this, so it would have to certainly be scalable a little bit. And then just sort of to review what Clark County is supposed to do, and we'll see what they actually do, is they review data and they identify gaps, identify statewide community databases that contain information about harm reduction and substance use to identify gaps, more data, and then look for trends including some sort of analysis of social determinants of health that may be prevalent. And then they are supposed to seek opportunities for collaboration to leverage existing resources to prevent opioid overdose fatalities. A couple things that we also wanted to make sure we included was culturally competent participation. So we have a spot for someone who can bridge that gap. So those are just some thoughts as things, if you noodle this on the road, making sure that it's not impossible to do.
Yeah, thank you for those comments, because I agree with you. What works in Clark County with the larger group is not definitely going to work in our rural and frontier counties. Rosalie, I have a question. Do we need to take a vote on this to move it forward as a continuing resolution or continuing recommendation?
I would do a vote for anything. Well, you could have something at the end that just says everything we talked about that we wanted to continue. Let's go ahead and include that. To the extent you're making any decision about it and it's not a default that you're including everything in the past, I would have some vote, but it could be at the end of this discussion and include them all.
Okay. So it sounds like we want to move this forward. We're going to have to just wordsmith it a bit to add that flexible, scalable, and at the community county level. And then we'll move on to number 4, fund personnel or resources for an independent medical examiners for investigations and reports to specify the cause of death in overdose cases. And based on some of the comments that Trey DeLapp provided for us, it sounds like this is a concern for both Clark and Washoe County in a terms of overdose fatality reviews being an impediment for their personnel in terms of not having enough and overburdening. Christine, did you push this one forward, if I remember correctly?
Yes, that was the one I put forward.
Do you have any updates or anything, or any comments you'd like to make about this one?
Other than since it is a concern for the coroner's personnel, if they could find funding to have someone fill that role without being a burden on the existing personnel, then that was the whole point, is that they need funding for someone to do that job specifically.
And I apologize, but can you refresh my memory? Was this for one independent medical examiner, or one for Washoe and one for Clark? Or did we not get to that kind of that fidelity?
We didn't get that far into it, or even if it was on a rotating basis where it wouldn't be like a full-time position, but someone who was given additional compensation for doing that role.
Okay, so you feel we should continue moving this forward as a recommendation?
I do.
Okay, any comments or questions for the committee members?
Chair Kearns.
Dr. Woodard, please go ahead.
Stephanie Woodard for the record. I did have a question, because this may have been part of a conversation that we've had in previous meetings, but is there, part of this recommendation is to fund personnel? Has there been a discussion on the who or the how as it relates to that funding? Who are we recommending fund the personnel and resources? And is there a specific allocation of funding that is being sought?
I don't remember having that discussion, but Christine, I'll defer to you. Did we have that discussion, or was there a recommendation of where that funding, or how we should try to achieve that funding?
No, we didn't get that deep into it.
Dr. Woodard, do you have any thoughts in terms of the funding?
So Stephanie Woodard for the record. I think at this point, less specificity is fine, but at some point, in order for this to be a recommendation that is specific and targeted, I think we're going to have to figure out where we want to direct the recommendation, whether it's a recommendation for local communities, or if this is something that needs to occur at the state level. And if it is at the state level, is there a specific agency that needs to be tapped for the allocation of funds? The reason that I say that is because if it is at the state level, then it may actually need to be considered as part of an agency budget request for the next biennium. Or it may be spending bill. Or it may be both of those things. So I think we just have to be thoughtful about how we want to approach a recommendation for funding.
Thank you for those comments. I appreciate it. Christine, I just wanted to ask, have there been discussions with Washoe or Clark County Coroner or Medical Examiner's Office about this?
No, I'm wondering if we can tailor the recommendation specifically for drug-induced homicide cases, since they're so rare that they actually go forward, that if it wouldn't be done on in every overdose case, but if they've got a case where they really feel like there's a good chance of prosecution, then we use that resource to get more specific as to the specific substance that caused the death.
Any further comments or questions from committee members?
This is Shayla Holmes. So this is not my area of expertise, but I know that from conversation with local law enforcement, part of our issue is that they don't have the funding to be able to test all substances that are confiscated. So we don't know really like the true amount of say fentanyl that's coming through other substances that are being confiscated. So we're not necessarily prosecuting or pursuing those cases to the level of which they could be, because we're not testing everything for fentanyl. They're only testing things for fentanyl which they think have fentanyl in it, which means we're missing a huge chunk of data. And I would think that making this recommendation in a similar mindset to only investigate drug-induced homicide, that we might be missing some information prior to getting to that step if we're not perhaps investigating the full scope of the death in an overdose anyway. I could be wrong on that, but I would think that it might be in our best interest to keep it for overdose cases. And while I realize funding is always an issue, I think that having that scarcity mindset and saying, well, if funding's an issue, maybe we should just focus on something that's smaller, that if that's not really going to fix the whole issue, if the issue is having that full investigation for any overdose, then I would say that we stick with the broader scope. Again, not having the full understanding of the next steps of that investigation, but that would be my thoughts.
Thank you for that. Any other comments from committee members? My thought was similar to what Shayla voiced in terms of I understand needing the funding to look at those, specifically to look at the drug-induced homicide cases. But the fear is, are they going to be missed because we don't have the data prior to? And would funding this position or finding funding for this type of position for an independent medical examiner also maybe assist with some of the workload on the overdose fatality review as well? So any other comments?
Chair Kearns, with your indulgence, can I make a comment?
Please, trade a lap.
Thank you. As I understand, when they do an autopsy on an opioid fatality or any sort of autopsy, I think they do a comprehensive drug screen panel that looks for everything they possibly can find. And I'm just sort of curious, another thing that came up in the discussion during the AB 132. So part of that experience was that the bill got gutted twice and somehow managed to survive. So go Magic. But some of the concern was, and I think this also came from best practices that if we created an independent review, and certainly there was a public member of the public who had this viewpoint, they wanted to have a fatality review that could be referred certain cases, and that kind of highlighted the value of the purpose of this process is to identify opportunities to prevent overdoses. And I mean, the conversation was this frank: what if some wealthy family decided to deploy or refer to this process to find out more about why their family member died? The reason that was kind of against the philosophy of this is the product of the OFR has no applicability for criminal action or civil action. And so getting that kind of review would naturally create something that, if it wasn't clear how that information would be used, it could be used in civil or criminal actions. So I'm not sure if that gels here, but I think it would be valuable to find out exactly what is screened for in a forensic analysis for toxicity, because I think it's as comprehensive as it could possibly be. And then also being mindful of having an independent medical examiner who determines a different cause of death or something than what the coroner comes up with creates the situation of, does this change death certificates kind of thing, or whatever. Just a thought. Thank you.
Yeah, thanks. Christine, do you have any comment to this? Because I think for the drug-induced homicide, it doesn't change what goes on the death certificate. It just is additional information. Is that correct?
That's the way I understood it. It was more, they do the tax screen for a regular autopsy, but this is specifically for the prosecution, because if they've got polysubstances showing up, then the defense is going to say, well, yeah, the suspect sold the fentanyl that was found in the system, but there was also methamphetamine in the system. So it was to be more specific of which substance actually caused the death, not just a panel of everything that was on board.
Okay, thank you for that. Dr. Woodard, again, I hate to call you out, but do you have any additional information you can add on for this independent? I know you talked about the funding and the funding source, but any other thoughts?
Stephanie Woodard for the record. Thank you for the question. It seems to me that based on the conversation that we're having here, that we probably need greater specificity and more information before we can really formulate a coherent recommendation. I think at this point, we know just enough to say whether or not we want to continue to pursue this. But I do think we probably need additional conversations to get greater detail here.
Okay, thank you for that. It sounds like we need to know specifically what is tested and the funding sources, and talking through the medical examiner / coroner's offices would be two examples of more information that we need. So it sounds like we still have a little work to do on this recommendation. If there's no other conversation on number 4, we also have for further review, resolve the conflict between the Good Samaritan Drug Overdose Act and drug-induced homicide law. Immediate actions may include recommending community level education using best practice guidelines, as well as education for law enforcement personnel. I know that this is coming up in our next conversation, so maybe we can push this one because this, as it stands, is just further review. So can we go to the next slide? So as discussed, this was a summary of our subcommittee recommendations under review. The first, as you can see, is to resolve the conflict between the Good Sam law and the drug-induced homicide law. And I think we had a great presentation on this, talking about specific instances when drug-induced homicide law would be in effect, and then also when Good Sam law would be. So maybe, as in the previous slide, this looking at the public health messaging for the Good Sam law might be a direction. I don't know that resolving the conflict is where we're going to be, but to have very specific media campaigns addressing the Good Sam law might be a direction in which we can take this. I'll open it up to the committee to see if there's further comment.
Chair Kearns.
Please, Dr. Woodard.
Stephanie Woodard for the record. So my recollection of this idea of resolving the conflict between the Good Samaritan law and the drug-induced homicide law was really more a guiding principle than a specific recommendation, and something that we philosophically wanted to keep in mind as we moved some of these policy recommendations forward, recognizing that in order to resolve the conflict, so to speak, it's relatively aspirational. I don't know if there's a day that we're ever going to say we have fully resolved that conflict. And so I think that in that spirit, looking to see how we may be able to move forward certain actions as recommended from this committee to at least promote things like the Good Samaritan law, and some of the conversations that have been had in the cross-sector task force around media campaigns and educating the public would be a direction that I think is more likely one to be able to meet some measured success versus trying to specifically resolve that conflict.
Thank you for those comments. And I agree that if we can take as an action/recommendation, it would be to maybe push this recommendation to the cross-sector task force to look at a public messaging campaign on the Good Samaritan law, looking at those public health messaging and best practices. Any thoughts or comments from the other committee members?
This is Shayla Holmes for the record. I think I agree that it's impossible to not agree that we need more messaging and education and community campaigns on the Good Samaritan law. I have some concerns on all of the if-thens that occur within our Good Sam law. And from the presentations that we've heard from both individuals with lived experience and then both our legal experts, I see where the difficulty in trusting that Good Sam law lives, and particularly the target population that really needs to understand that Good Sam law or really needs to buy into it is our individuals living or using, right? Our individuals that are actively using in the community are the ones that really need to understand that Good Sam law and utilize it. And so I think yes, we should, but I do think there is still some work to be done in how we can reduce those scenarios of you're protected by Good Sam, but not, like there's all of these little nuances to it that for an individual actively using substance might go, whew, that's too intimidating for me. I'm not touching that with a 10-foot pole. And so they choose to, like we've heard folks say, maybe call but hide in a bush or push naloxone and run. And so yes, I think we need to push this to the cross-sector task force. I think we do need to get started on doing a better job at educating and doing a good media campaign. But I think we also still need to investigate where those inadequacies live, so we can hopefully make some additional changes to streamline it for folks that are going to be the ones really needing to buy into it and trust the system when it comes to this law.
Thank you for those comments. One of the things I did was try to look at our areas that we should be addressing: the impact, capability, implementation, urgency, and racial and health equities. And I had a few of the things that both of you talked about with Dr. Woodard and Shayla, is that qualitatively we've heard from members and in legislative testimony that people who witness an overdose are not calling out of fear for arrest. Qualitatively, law enforcement, when appropriate, and there's evidence of tracking, will speak with prosecutors about charging and arrest. But from what we've heard from some of our committee members and law enforcement is there aren't a lot of cases of evidence of trafficking where they've taken it forward with the person who called or who was present during an overdose. But the impact is, we believe there are people who may be dying of overdoses due to people not calling, but we really don't have a quantitative number of how many that is. We just kind of have stories that that's happened. And then there are a few cases of people present during an overdose being charged or prosecuted for trafficking, but not a lot of these. Because it has to meet the element of the crime to be charged with drug-induced homicide. From my aspect, the capability and implementation, both are already laws. So I don't think legislatively at this point, unless we would make recommendations for amendments to those. But I said public media campaign for public as well as media campaign for LE. And maybe it's not a media campaign for LE as much as a training for law enforcement. It wouldn't be difficult. But we would need to provide specific information, to your point, Shayla, and on target populations for the public media campaigns. So perhaps that is something we can push to the Joint Cross-Sector Task Force. The urgency, I felt this was important because we need to ensure that it's done properly, the right message, the right route for the right target audience, and then the right message for that targeted audience as well. And then the racial and health equities, this would address people who use drugs as well as other populations that disproportionately experience overdoses. So how do we get to that quantitative data of witnessed overdoses, but no one called? I know there is some data that came out of the overdose data to action on talking about witnessed overdoses, but not necessarily witnessed, but and the person died. So those were just some of my comments, and I'll open it up to the committee to see if you have further comment or question.
I know this is Shayla Holmes for the record. I know we're not to the motion part of this conversation yet, but I would feel, since we have a couple of recommendations on this further review from last year, to move forward this recommendation as opposed to the specific legislative language. But I think also noting somewhere that we know that there still needs to be additional work done when it comes to getting that data, kind of how you mentioned, Dr. Kearns, with the who's overdosed that was witnessed that didn't call. I'm not sure how we would ever really get that, but I do think that there's some additional work to be done there, but I think this would be a recommendation I'd feel comfortable moving forward at this point.
Thank you. I appreciate that. And if I can have the indulgence of the committee, I know that Elise is on the call, and she was over the overdose data to action grant when that study was done. Elise, do you have any further detail as to that report that talked about data on witnessed overdoses?
Hi, Terry and committee. I don't off the top of my head. I think that was that from the SURG data, the unintentional drug, the state unintentional drug overdose repository data?
I don't remember. I just remember it was done out of the overdose data to action grant, I thought.
Yeah, I actually don't know if that was OD2A. I know that one of the things that OD2A looked at that we can see through, or that we could see through the coroner's data is like unhoused population, so people that died in their home or a home setting versus the number of people that were unhoused. And there's a huge difference, right? So I think most people who die by unintentional overdose die in their home. And then there's also a data point on bystander presence. So I think the last one I looked at was like 68%. Now that I've rambled enough, Terry, I remember I think the report you're thinking about actually came from Dr. Wagner and her work. They had looked at EMS and 911 data. I think his name was Femi, was working with Dr. Wagner.
Thank you, Elise. We'll reach
Thank
out
you.
to Dr. Wagner to get that report from her. But I do remember hearing that there was a high percentage where overdoses were witnessed by bystanders. So it sounds like from the committee and based on the comments I've heard that we need to refine the language and maybe move this to the cross-sector task force as developing a media campaign to educate on the Good Samaritan law. I don't know, committee members, if we should also target training to law enforcement at this point, what your thoughts are?
Chair Kearns.
Dr. Woodard, please.
Stephanie Woodard for the record. So I think for me, the word that I keep coming back to is media, like a media campaign. And I really resonated with what Shayla is offering related to really targeted messaging specific to individuals who use drugs, and then some education and messaging for law enforcement. So I think that if we can at some point come back and wordsmith this, because I don't know if a media campaign is necessarily what we're looking for, as opposed to a public health messaging campaign and potentially some education opportunities.
Thank you. I think that's better, public health messaging and perhaps training to law enforcement. So the recommendation would read more that this recommendation be considered by the cross-sector task force to look at a public health messaging best practices to educate the public on the Good Sam law, and then looking at targeted messaging.
And then I think I'm missing how we get an education for law enforcement in there.
Is it yeah, education / training for law enforcement? So would it be just to include education / I don't know, education / training for law enforcement?
How does that look? I'm trying to get them as good as we can so that you guys can keep going. So I know I've typed a bunch of things in here just trying to capture the conversation, but this is the one that we're currently working on. Request this recommendation be considered by the cross-sector task force to look at public health messaging best practices, to educate the public on the Good Samaritan law and target messaging to people who use drugs, include education and training for law enforcement. I think that last part might need some work.
Chair Kearns.
Please go ahead.
Stephanie Woodard for the record. I would suggest changing the word target to targeted so that there's targeted messaging created for people who use drugs.
Thank you for that. So as it stands, does this look like a recommendation that we could forward to the cross-sector task force to be considered?
Yes.
For clarification, I had this part, investigate where inadequacies exist in statute. I think that was something, Shayla, you were saying as for further review. So I wanted to see if we were supposed to be noting that for further review for this subcommittee.
I don't think that's something we want to pass forward or move forward to the cross-sector task force, but I would certainly encourage the members of this subcommittee to push forward as far as the recommendation goes from us going into next year.
So this is kind of a still needs further review by investigating where inadequacies exist in the statutes.
Feels like there's a 2 missing from that statement, but we don't have to get too detailed right now.
Okay, I feel like we're good on this one. Can we move to the next recommendation?
Yes, and actually things will pick up from here because the recommendations repeat. So I think just if you were reading ahead as Dr. Kearns was, this, you'll note that we had several of the same type of recommendation or recommendation in the same vein, which was around the Good Samaritan law and drug-induced homicide. I believe that's the case with recommendation number 2, as well as number 5. So Chair Kearns, I would ask for your direction on what you'd like to do with these similar recommendations.
Okay, and I think that the recommendation number 2 was Shayla's. And if I remember in the presentation that we had, our staff, the deputy, looked at Delaware and Rhode Island's and felt that ours was, our Good Sam law was as comprehensive as those. But Shayla, I'll defer to you for your thoughts.
No, I agree. After hearing from our experts here within the state of Nevada, and I think that what I attempted in this recommendation is captured in that further review from the previous recommendation. So I'm not sure if this requires us to go into any in-depth conversation. I think that for me, in regards to Good Sam and where we're at right now, based off of what we've learned over this past year, recommendation number 1 captures where I'm good at for the moment.
Thank you. And I think we can just keep those in mind as references, Rhode Island and Delaware's.
Okay.
Okay, so I think then we can move on to the next recommendation, which is recommendation number 3, which Dr. Woodard, SUD, mental health, substance use disorder, mental health, medication for opioid use disorder, assessment, treatment, recovery support, pre-release case management availability in incarcerated settings, implementation challenges and opportunities, and the 1115 waiver for Medicaid coverage 90 days pre-release, which is a lot in that wording. So Dr. Woodard, did you have any comments or further narrowing to a recommendation?
Yes, Stephanie Woodard for the record. So that's not even a complete sentence. It's really more of a brainstorm. So I took some time to try to put into words really what I was attempting here. So what we know is that it's one thing for a state to move forward with an 1115 waiver or any type of authorization for services within a Medicaid population. It's another to ensure that the system that would be providing those services and billing Medicaid for those services is in a stance of readiness to be able to do so. And so this recommendation is relatively comprehensive, but it really must require two specific components. The first is to evaluate the current availability and readiness to provide comprehensive behavioral health services. And then I'll slow down, Crystal, so you can catch up. And we can go back and wordsmith from here. To include, but not limited to, screening, assessment, treatment, recovery support, and transitions for reentry in local and state carceral facilities. This work in some capacity is already being done through the Department of Health and Human Services. We have a fairly extensive needs assessment that's occurring, which will give us a good snapshot on jail by jail, as well as Department of Corrections, where each facility is in relation to being able, either currently providing or being able to move to a place where they're able to provide these services. This is an important piece that sometimes gets missed, and we just jump right to the solution, which is let's allow jails and our Department of Corrections to be able to bill for services. There's a lot that's going to need to be able to happen in order for them to be able to make use of a waiver. So the second piece of this is to recommend the allocation of funding to support the development of a Medicaid reentry Section 1115 waiver to increase healthcare. And these are in, sorry, this is going to be in all caps, because this is the kind of waiver that it is. Healthcare for people leaving carceral facilities. To support readiness of carceral facilities to implement the 1115 waiver. And sorry, Crystal, I didn't mean all caps. I just meant the title is capitalized. Sorry, I misspoke.
That makes more sense. That's a quick fix.
Dr. Woodard, while Crystal is changing that, I had a question for you. For our state, they have gone through the process, but have not been approved yet for that 1115 waiver. Is that correct? Or am I misunderstanding where we're at?
Stephanie Woodard for the record. So two different waivers. We have an 1115 substance use disorder treatment waiver that has been approved by CMS and is currently working through some of the nuances to be able to implement. This is a new waiver that the state would need to apply for.
Okay, thank you. And is the plan that the state is going to apply for this new one?
Stephanie Woodard for the record. So when I think of the opportunities here, I think we also have to look at different strategies. So one certainly is to recommend legislation that would authorize the Division of Healthcare Finance and Policy to apply for and implement this specific 1115 demonstration waiver. It's been done in the past with the substance use disorder waiver. What that does is when it puts it into statute, it then becomes a requirement that then can help to drive the budgeting process for it. So I think that is an essential component. And then also ensuring that there is that evaluation and preparation for readiness that is supported at the state level as well, because that oftentimes requires additional funding and work for both the pre-planning as well as implementation support.
Crystal, I think at the beginning it's recommend legislation. Yeah.
I don't know if that's for so maybe it's not. I
That
don't
would-
know CFP.
Yeah, it would be to require.
Thank you for the great kind of whittling down and clarification on this. Any comments or questions from committee members? Dr. Woodard, do you know at what point, I know you said that DHHS is already working on the evaluation of our prisons and jails to be able to implement MAT? Do you know when that assessment will be completed?
Stephanie Woodard, for the record, I don't. I believe the individual who's conducting those on-site assessments is looking to wrap that up by January, I believe. Don Yohe would be able to give you a more concrete date. And then the goal is to come alongside those jails and Department of Correction to continue to support them with any kind of training or technical assistance necessary to help them move this process forward, right? We don't want to wait to do the work that we know already needs to be done. We want to prepare the system so that it can continue to evolve and meet the needs of individuals who are incarcerated.
Great, thank you for that update. So I'm going to just read what Crystal wrote just to make sure we sound good. For the recommendation is first, to evaluate current availability and readiness to provide comprehensive behavioral health services to include but not limited to screening, assessment, treatment, recovery support, and transitions for re-entry in local and state carceral facilities. Recommend the allocation of funding to support the development of a Medicaid re-entry Section 1115 waiver to increase healthcare for people leaving carceral facilities and to support readiness of carceral facilities to implement the 1115 waiver. And then the last component is recommend legislation to require DHCFP to apply for and implement the 1115 waiver to increase healthcare for people leaving carceral facilities and ensure there is an evaluation of readiness for planning and implementation.
I think that increase should have been maybe.
To implement. So any questions or further discussion from the committee members?
Chair Kearns, Stephanie Woodard, for the record. It is actually to increase, so it would be just capitalized increase.
Oh, that's okay.
Thank you for that clarification. Okay, at this point, I think we're good. We have good direction for this recommendation that we can move on to the next. Which was pushed forward by Shayla Holmes for the wastewater-based epidemiology. Shayla, would you like to provide comment on this recommendation?
I have not wordsmithed it to a degree of which might make this simpler. We probably could delete some of this language, but I do think based off of the presentation that we had, it would be in our best interest as a state to move forward with some investment in wastewater epidemiology.
So at this point, it's maybe move forward with further review for the investment.
Yeah, I think we need to figure out what that true cost is.
Yeah.
The benefits sound great, but there is a lot of unknown when it comes to utilizing this technology, I guess is what it is, in this arena, because they've modeled it and they've used it in some capacities. And I think that in other states, they've shown that it can be beneficial, particularly when it comes to response.
Okay, so it'd be to understand the true cost before we can really make the recommendation for cost.
See Dr. Woodard's.
Dr. Woodard, go ahead.
Thank you. Stephanie Woodard for the record. So when I think of this specific recommendation, I'm reminded of a quote that I will not get exact, but we are drowning in information, but thirsty for wisdom. And I think that it holds true that we have so much data that we currently have access to that I think is much more actionable, that we still are not fully utilizing to the best of our abilities to even provide some real-time or as close to real-time surveillance for our communities as possible. And so while I agree that some kind of wastewater-based epidemiology could be helpful, I don't think that we're currently optimizing the available data that we have to be actionable in our communities to inform our approach. And it is not clear to me how additional information used from wastewater-based epidemiology can then be turned into something that is additional information that can help to build approaches that can be actionable. So I think that for me, in order to move this recommendation forward, I also really want to understand how what the best practices are, that this data will be used in a way that communities can make it more usable versus additional surveillance, because we've got so much surveillance that's already going on, and all of that information still isn't hubbed in one place.
This is Shayla Holmes for the record. Thank you, Dr. Woodard, for that. I totally agree on the tons of information and data that we have. I think back to when the OD2 mapping first came out. Gosh,
Overdose data, OD map.
OD maps, yeah, like six years ago, I think, and the coalitions were charged with creating response plans in hopes that we would be able to utilize that mapping system, but we didn't get that local level community buy-in to actively use that mapping system in real time. So what has been put in place is almost great, in that we've got some of that overdose data now coming directly from the hospitals back into that system, but it's not real time. And so for those response or spike plans, I don't think any of our rural communities have been able to actually implement or utilize any of those spike plans. And I also think those spike plans can be revisited and be enhanced in a big fashion. That's that secondary step, right? That's that, how do we take this data into action? But we don't have good mechanisms for that real-time action at this point. And so I think we either can go back to what that looks like in utilizing our first responders, getting community-based buy-in, and utilizing that mapping system the way that we had originally believed it could have been. This wastewater, based off of the presentation that was shared with us, that gentleman shared that it's not only just overdoses, it's then also any of the prescription drugs or anything else that's happening, and nearly almost real time, as much as it's going through the human body within 24 to 72 hours, that it's real time and can be done in a really pinpoint location to where we could be better prepared. But I think you're right that what would we do with this information right now? I don't think we're equipped at this point in time for that. It's like the chicken or the egg, right? We can build these great response plans, but if we don't have the data to inform them, then we're not utilizing them, which is why these spikes and response plans have just sort of sat there stagnant and now I don't think are really applicable anymore and would need to be revisited. So I think we need to figure out a way to make these happen parallel to each other so they could actually be implemented and used and have the community see it in action and better it, right? That cycle, you know, that PDSA cycle. We've got to try it before we know how to fix it, but we haven't tried it yet.
So it sounds to me, and I could be wrong, but as I'm looking at it, it's more to optimize the available data to inform actions and maybe to inform actions and update the community response plans.
I would agree with Dr. Woodard 120% on that. We've got to have the action step tied to it because otherwise we're just dataing to data.
And then the second part would be just to look at the true cost of implementing wastewater-based epidemiology and maybe any best practices that have used this. So it's almost two separate.
I would agree with that.
I almost feel like the first one, optimize available data, inform actions, and update community response plans, is something we could push forward. To better understand the use for and true cost of wastewater epidemiology is something we are going to have to research more.
Chair
Thoughts?
Kearns?
Go ahead, please.
Stephanie Woodard, for the record. I can't recall which recommendation we had discussed this, but my understanding is the impetus for that cross-sector task force that was developed with both the SURG and the ACRN was really to do a lot of what Shayla is talking about. What do the communities actually need at a local level, whether it's revisiting the spike response plans or understanding how to better utilize the data, so that there can be the stance of readiness in communities to be able to respond. Does it make sense to somehow connect the optimized available data to inform actions and update community response plans also back to the cross-sector task force so that we may be able to sort of bring this recommendation to them?
Yeah, I think that sounds like a good idea. It's not something that's really new, but it's the expansion of existing programs. Shayla, what are your thoughts?
I don't think that it could hurt sitting in on some of those cross-sector task forces. I do just want us to stay aware of, don't mind that sound, I apologize. I think we need to be aware of what they're choosing to do as a part of that task force, because really I feel that as a response committee, a lot of what the work we could do could flow into that task force as far as what a community level response looks like. And I would hate to abdicate our voice and our action fully through that task force. Not that I'm saying that we're doing that, but I think we should be aware of what they choose to work with. And we may or may not agree of what they choose to work with. So I would hate to, I don't want to lose track of them just by also involving that joint task force in the conversation. And if they pick it up in action, awesome. I think we can check that off as we've achieved something. But if they don't pick it up, I don't want to lose it through that process either.
Okay, so we can make the recommendation to the joint cross-sector task force. And if they choose not to, then we will keep this as a recommendation. Is that what I'm hearing?
Do you want me to add language that says that, or is it enough that you'll recommend?
Stephanie Woodard, for the record, I would recommend that we add it in here so that it doesn't get lost, and that we can ensure that this recommendation continues to move forward regardless of the body that is working on it.
Thank you for that. I think we're good then on this recommendation. We can move to the next, which I think we've already addressed, which is the resolve the conflict between the Good Sam and the drug-induced homicide. And as Crystal informed me, she put this twice because it was recommended a number of times. Oh, number 6. Leverage existing programs and funding to develop outreach response providers and or personnel that can respond to any suspected overdose or to those who are provided treatment for an overdose in a hospital emergency room EMS and offer follow-up support referrals and services to the individual and loved ones following an overdose. Providers and our personnel to be deployed to anyone being released from institutional and community settings, hospitals, carceral facilities, and other institutional settings who is being discharged post-overdose or suspected overdose. We do have some of this that exists in some places already with some of our teams, not to this extent. And I don't know if there's any crossover with any of the crisis response. So I would defer to my experts on crisis response if we're delving into any of that territory.
So Stephanie Woodard for the record, Chair Kearns, if I may.
Please go ahead.
I would say yes and no. So in an ideal crisis system, it would be able to respond appropriately with necessary supports, regardless of the nature of the crisis. So not really differentiating the difference between an individual who has survived a non-fatal overdose versus others who have been experiencing other kinds of behavioral health emergencies or crises. That being said, I do think that there is still a need and an emphasis for tailored intervention for individuals who have survived a non-fatal overdose. We know that individuals' risk for subsequent overdoses goes up exponentially when someone has survived an overdose. So ensuring that whatever the crisis system is developing also takes into account specialized and tailored services for any number of issues, including individuals who have survived a non-fatal overdose. So I don't think that we need to separate it out, like we need two different systems. I think if anything, we need to ensure that this recommendation is included for consideration as the build out of the crisis system is occurring.
So as revised, it is, as Crystal wrote, ensure this recommendation is included as the build out of Nevada's crisis response system is occurring so that tailored intervention for individuals who have survived a non-fatal overdose are included. Is that correct?
That's correct.
Any other comments or questions from committee members? Okay, is that the last recommendation or do we have?
We have the two that were discussed. Let me actually just keep scrolling to make sure I'm not wrong. Okay, so 7 and 8 were our 2022 recommendations that were discussed today for possible reintroduction.
So just going back, if looking at my notes, is that it's more to to continue to follow this for the report out of Clark County that's due in 12 of 2024, and then to look at moving forward with a flexible, scalable practice at the community or county level.
Chair Kern, Shayla Holmes for the record.
Please, go ahead.
I'm not sure what the right language is. Some hesitancy at putting it at the county level, because as was shared, some counties don't have that breadth of expertise, but I think, and probably don't even have, enough overdoses to warrant a regular meeting. But I think there could be, for some of those smaller counties, the need for a regional approach. And so however we can wordsmith this to not go county level, because I think that would be overwhelming to some counties. Community level might be appropriate, and letting counties identify what equals their community that would be applicable to an overdose fatality review. Or it could be counties and or regional as needed. That might be better language for how we make that recommendation. I just think going all the way down to the county level for some of those would be hard.
Thank you for those comments. I think that's well taken. So have it at the community and or regional level would be the second part of that.
Stephanie Woodard for the record, Chair, if I may.
Please.
When Shayla was describing some language, I think keeping it at the county or regional level makes sense. My concern with the word community is community can be defined in any number of ways down to a neighborhood. And so I think being specific, and it is consistent with legislative language to put it at the county or regional level, and the regional the behavioral health regions are already well defined in statute. So I don't know, Shayla, if that's kind of what you were thinking, was to leave it to the county or the behavioral health regions.
I think that's what makes the most sense, particularly when you look at our frontier region. And if counties want to take it up as an individual undertaking, awesome, more power to them. But if not, at least we have that backup plan on those regional sections.
Sorry, this is Crystal. I just wanted to add that what you see here is a revision from the 2022. So when you were discussing this earlier, I did add flexibility as to the makeup. So I just wanted to be clear that what you saw here is not just the 2022 recommendation. It already has been revised, but it sounds like we might need to revise it further to incorporate reviewing Clark County's OFR.
Absolutely. And then Crystal, in that second line there, scalable OFR at the remove community and make that county. So it'd be county or regional.
Okay, I think that looks good. And at this point, I know it's 10:30 and I think we're going to run just a little over. I just want to ensure that we have all of our committee members who can stay on for a little bit longer so we can finalize this. Do any committee members have to leave?
I should be good until about 11:15.
Okay, hopefully we won't take that long, but okay.
Just to make sure I understand, so we would use this support legislation to establish and then add, in addition, the subcommittee will review Clark County's OFR report when released in December 2024. Or I guess that's a recommendation back to yourselves to review it. Maybe that's not what you want to do.
Stephanie Woodard for the record. I think in order for us to make any recommendations for further legislation, we need to take into account the operations and lessons learned from Clark County's OFR. So I think it's both of those things. It's really making sure that we understand kind of lessons learned and then take that into account as we make recommendations for legislative language going forward.
Probably way too long of a sentence, but something to that effect. Oh, that didn't cut and paste in the right place. I'm sorry. I can wordsmith to take into account out twice, so we'll figure that part out.
Okay, but we've got the idea that it's to get the operations and lessons learned from Clark County's OFR report released in December of 2024 when supporting legislation to establish regional OFR committees that allow for flexibility as to the makeup and practice, and for the OFR to remain at the county or regional level. Okay, any further comment or questions from the committee? Okay, let's move on to the next one. This was the funding for personnel and resources for independent medical examiner for investigation and reports to specify the cause of death and overdose cases. And I think in our discussion from this, we needed to get more information in terms of what our coroner and medical examiners currently test for. And then the funding, is the funding, are we looking at an agency specific request for funding, or where would the funding come from? So while we want to continue to move this forward, we need to get more information. Christine, I'll reach out to you first and see if there's anything specific that you recall that I didn't in this one.
Nothing that I can think of.
Other committee members? So we'll keep this, move it forward, but our recommendation is we need to further establish or further research to understand what the coroners and medical examiners are currently testing for, and then the funding source. So recommend if it's an agency specific funding or from other sources. Any other comment or questions on this one? So this is a continue to follow, but okay.
Chair Kearns, can I just mention before we move, I don't know if you're ready to move to the next.
Go ahead.
One thing we haven't yet done in this discussion is ensure that I can pull the justification and things like that for these prior recommendations. I can pull that forward. But we haven't rated them for the impact, the capacity, and then how the recommendation or had a discussion of those things. So those items will need to be filled in. And so I would just ask that the subcommittee continue discussion or make a plan for that, which I am happy to move forward with.
And we need to do that for each of them, you said?
Probably not all of them. All of them do need this one filled out before we can go before the SURG. So, because we have, that was not on the survey, is how it advances racial and health equity. So there are holes in each of them that we need to fill, I would say.
Okay, and do we have another recommendation, or are we?
That was just a blank space in case we
Okay.
needed. So I think we're
Okay.
good on new
Okay.
recommendations. I could make a proposal to resend this document with information pulled from the prior year's report as it pertains to 2022 recommendations, and ask that committee members fill in additional details for those 2022 recommendations, as well as the 2023 recommendations that do not have that information. That would need to be done, I guess, via email.
Yeah, and you would push that out.
Yes, I can do that.
Okay, I think in lieu of time, we're gonna need to do that. I guess the question, we're to the point now where we would need to have someone make a motion to move these recommendations forward as we have revised them. Is that okay to do at this point, Rosalie?
Yes, you can go ahead and do them as kind of bulk. It doesn't really matter how you organize it, so long as it's just clear for the record. How you want to make the motions.
Thank you. Do we have a committee member who would make a motion to move these recommendations forward as from the response subcommittee as revised?
Stephanie Woodard, for the record, so moved.
Thank you, Dr. Woodard. Do we have a second?
Christine Payson, I'll second.
Thank you. So Dr. Woodard forwarded the motion and Christine Payson seconded. And I would say I do need to go back for the minutes. I didn't take a vote on them. So for our minutes, it was that were moved and seconded. All committee members that approve the meeting minutes, say aye.
Aye.
Anyone opposed? Any abstentions?
Chair Kern, Stephanie Woodard, for the record.
Go ahead.
I vote aye on the approval of the minutes in form but not content. I was not present in that meeting.
Thank you. And I just want to make sure I only heard one aye for the approval of the minutes. Do all the committee members, then having heard no in opposition, approve?
Christine Payson, for the record. I lost sound for a minute, but I vote aye.
Thank you. Okay, they are approved. So at this point, I'm sorry to make you go back, Crystal, but I will turn it over to Chair Holmes to discuss the report out for the October surge.
To Shayla Holmes, for the record, to keep this brief, what's going to happen at our October surge meeting is the recommendations and what we just discussed, or what will also be working via email, is what will be presented by Chair Kearns. And if for any reason Chair Kearns isn't available, it'll be done by me, but Chair Kearns is totally going to be available. And then at that point in time, any of us that have sponsored or requested these recommendations will have the opportunity to add additional information, much like how this meeting went today. And then there will be an opportunity for the entire surge to have conversation regarding those recommendations. And anybody that has a different or dissenting opinion from what we are putting forward on these forms is more than welcome and encouraged to share what their concerns are. And if anybody wants to share right now that you are in opposition or don't agree with some of those recommendations that we discussed, having that knowledge ahead of time, we can call on you specifically during that meeting to make sure that your thoughts are heard and taken into consideration with the greater surge.
Thank you, Vice Chair Holmes, and that the October Surge Committee meeting is October 11th. I think it was moved up to 9 a.m. Is that correct, Crystal?
Yes, I think it was originally in the afternoon.
Yeah, so October 11th at 9 a.m. Thank you for that. Moving on to the next agenda item is public comment. Crystal, I'll read this for you. I know that your voice is stressed today. Public comment will be received via Zoom by raising your hand or unmuting yourself. When asked for public comment shall be limited to 3 minutes per person. This is a period devoted to comments by the general public, if any, and discussion of those comments. No action may be taken upon a matter raised during a period devoted to comments by the general public until the matter itself has been specifically included on an agenda as an item upon which action may be taken pursuant to NRS 241.020. If you are dialing in from a telephone, dial 669-444-9171. When prompted, enter the meeting ID 868-333-11069, and please press *9 so the host can prompt you to unmute. Do we have any public comment? We'll give it just a minute in case somebody needs to get unmuted. While we're waiting, I just would like to say that I want to personally thank Dr. Woodard for her service, both to the state and to the SURG and to the SURG subcommittee. Most of you probably already know, but we unfortunately will not have Dr. Woodard on this committee anymore. She will be, or on the SURG, she is going to be departing from DHHS. So I personally want to thank you, and the committee thanks you for all of your input. It's invaluable, and we will miss you, but understand. Any public comment, Crystal?
I did not see any hands raised or anyone come off of mute to make public comment.
Okay, so at this point, we'll move to the next agenda item, which is the adjournment. Thank you all for your time. I apologize for going over. I don't like to go over, but I wanted to get this finalized today. Thank you.